For the kind introduction. Respected chairpersons and friends, a very good afternoon. And I would like to thank the organizers for giving me this opportunity to share my experience as a physician working in a bariatric unit. When I was doing my post-graduation, the Harrison textbook of medicine that time mentioned just about 2 lines about weight loss surgery. Even the word bariatric did not exist at that time. And what it particularly mentioned was that it gives rise to a lot of nutritional problems. So I always had that fear in my mind, and when I started working in the bariatric unit, I was always on an alert to see how many actually patients are going to need TPN and how many are going to be admitted and have nutritional problems. So basically, the post-surgery nutritional care starts in the pre-operative period when we are preparing these patients for surgeries. So bariatric surgeries are basically planned surgeries, and there's no emergency about it. So we get lots of time to prepare these patients, and we try to nutritionally correct them. So obesity is a multi-organ disease with various comorbidities which pose a risk for anesthesia, with a range of existing nutritional deficiencies which may affect the wound healing and post-operative quality of life. So the pre-operative evaluation is important for identifying the pre-operative and post-operative challenges. So this is just a diagrammatic representation of the various comorbidities which are associated with obesity from head to toe. The comorbidities itself, they present various nutritional challenges, but most important is obesity itself is associated with various nutritional deficiencies which we were not earlier aware of. So what are the challenges or the factors which are predisposing to deficiencies when a patient is going to go in for bariatrics? So basically there are existing deficiencies maybe because of various reasons. For example, vitamin D deficiency. The patient is very morbidly obese patients. They don't have a social life. They don't have an active lifestyle. They don't go out in the sun. They don't exercise. Their protein content is low. So their lifestyle may be very wrong. Their eating may be very wrong. So there are various factors which are responsible for deficiencies which exist in an obese person. Secondly, when the patient undergoes surgery, there are various diet phases through which we take the patient for a good healing of their anastomosis and all the suture lines that are inside the body. So during these diet phases, it's like from clear diet to solid food, and that's why, again, then in that case, nutrition may take a backseat. Third important thing is the surgery themselves, they present a volume restriction. So the amount of food that a person eats at one time may be just 1/4 of what they were eating previously. So again, the perfect balanced nutrition will not be available in that small amount of food that they take. Fourth important thing is the hunger control. So there is a very good hunger control following bariatric surgeries because of the decrease in the ghrelin hormone, and so that is another thing because of which the patient, whenever is eating, will not overeat, will not eat for a large volume, may not feel very hungry to eat, and so again the nutrition may be definitely less. The next important thing is the decreased acid. So because these are surgeries on the stomach, there is decrease in the hydrochloric acid which is available to break down the nutrients from the food which the patient eats. So that is another reason, another thing which we have to remember. Then fifth is the malabsorption. The malabsorption itself is deliberate malabsorption. So we want to decrease the fat absorption, but that does not happen alone. Because of decrease in the fat absorption, there will be decrease in the fat soluble vitamins which are available to the body. So, and there are everything else also gets affected. The most important thing is, of course, the lifestyle of the patient, what the patient eats, when he eats, and how he eats. So all these factors come into play. The affordability of the person, whether the person has access to nutritionally correct food, to accessibility to various supplements. Then the compliance, which is again a very important factor in any weight loss program. And fifth important thing is whether the patient, the team, the dietitian, whether they understand exactly what are going to be the nutritional challenges after surgery and how they can overcome them. So nutritional assessment in the pre-operative period is very important. These are various, various people have already did lots of studies on the nutritional status of obese patients and who are undergoing to go bariatric surgery, and they have found that many of the vitamins and minerals are deficient. Most important is vitamin D, calcium, which we have also studied very extensively. So there is a state of secondary hyperparathyroidism. Then you have the B complex. We have the B12 deficiency, very common, and folic acid deficiency. B1, B6 is also known. And B12 we see in many of our diabetics, for example, those who are on metformin or those who are not taking adequately correct diet, our main vegetarian population. So that is a very important factor where we know that this person is going to have B12 deficiency. So in your preoperative screening, there are certain things which should be, that you should do. Then serum iron, ferritin, TIBC, especially in the younger females. It is very important too. Even in males, we have seen that they have iron deficiencies. The fat-soluble vitamins, we do not routinely do this. And the access also may not be available easily. But if you are going to subject a patient to a very malabsorptive procedure, you should have in mind that, okay, the person is going to get these fat-soluble vitamin deficiencies. Then other things which be low in obese patients are zinc, copper, selenium. And of course, in our country, in vegetarians, we have to think about the protein. So what is important to remember that these deficiencies would worsen post-surgery, more so if the patient is going to undergo a malabsorptive procedure. And therefore, you have to diagnose them and correct them before surgery. Now, what happens during the pre-operative dietary preparation? The patient is on a very low-calorie liquid diet. So in such conditions, we make use of various meal replacers so that they get some adequate nutrition, and we try to correct their vitamin B, the vitamin D, we give them iron, vitamin K, and protein as required as per the patient's laboratory profile. In the immediate post-operative period, say from the day of surgery to first 2 to 3 months, the patient is going through various diet phases, which consist of clear liquids and thick liquids, porous consistency, soft diet, and then to the regular food. So we make it a point to see that the second to third week, the patient starts with the protein supplements, then with whatever vitamin supplements, especially one which existed as deficiency in the preoperative period, and secondly, those which we expect to be challenged. From the third month to say the time that the weight loss is happening, that up to 1.5 months, 1.5 years. So we see to it that we try to do the metabolic and nutritional workup at 3, 6, 9, 12, and 18 months. This also keeps the patient in touch with us, and accordingly we supplement. And we ensure that we educate our patient properly, and that the patient is taking nutritionally correct diet. In the lifelong nutrition post-bariatrics, there are certain success habits which a person should follow, and our role as a bariatric unit is to educate our patients properly. So high protein, moderate carb, low fat, nutrition-rich diet, frequent small meals. Again, do the metabolic nutritional workup every 6 to 12 months, supplement accordingly. But we continue with the protein, we continue with the B12, we give occasional vitamin D, and we give a multivitamin which has many of these vitamins and trace elements. So this is how we ensure, we see to it that the patient comes for follow-up, the patient is doing some sort of physical activity. So morally we try to keep the patient motivated. So we teach them about the portion size, that include fruits in their diet, include a lot of salad, so fiber in their diet, take plenty of liquids in between their solid meals. And lots of protein. So vegetarian patients, the various grains. So non-vegetarian patients, chicken, fish, and egg white. So what do we teach our nutritionists? That the bariatric surgery brings about anatomical changes, and these anatomical changes give rise to various physiological changes. So procedure-wise, the anatomical change can be on the stomach only, or it can be the stomach and the intestine. The physiological change is that there is change in the digestion and absorption of food according to the change in the hormones, and also the contact time of the food with the various enzymes. So absorption of protein, carbohydrate, fat, as well as vitamins, minerals, trace elements, everything is affected. So what we need to remember, and what we teach our dietitians about the micronutrients, the micronutrients, and just as a revision, you know that protein digestion starts in the stomach, where it is broken down into peptides by the pepsin enzyme, which is activated by the hydrochloric acid secreted by the parietal cells. And what happens in those procedures, for example, like it is not just one procedure, all procedures there is decrease in the stomach size. So this is one of the major challenges, that because the hydrochloric acid decreases, breakdown of various substances becomes a problem. So protein, this digestion starts in the stomach, and the absorption is with the help of the pancreatic enzymes, which is in the small intestine. For the carbohydrate digestion, it starts in the mouth with the help of the salivary amylase. So post-surgery, this factor becomes very important, and we insist and we teach our patients that they should chew the food properly before they swallow the bolus, because that will help the contact time with the salivary amylase. So in the intestine, the various other enzymes, they break down the carbohydrates to monosaccharides, and then it is absorbed in the small intestine. The fat digestion requires bile acids. So fat digestion, nothing in the mouth, nothing in the stomach, directly in the intestines. It requires the bile acids for emulsification of the fat globules, and it requires the pancreatic lipase enzymes, and then the fat is broken down into monoglycerides, and it is absorbed in the small intestine. Another important thing we have to remember is the B12 digestion. So these pink things are the vitamin B12, the blue things are the intrinsic factor. And in the stomach, the parietal cells, they secrete the hydrochloric acid, which is required for removing the B12, especially from the animal food. And then this intrinsic factor secreted by these parietal cells with the vitamin B12, they travel down, and in the terminal ileum, it is the whole complex is absorbed, and then the B12 is broken down. So all those procedures where the stomach is size is decreased, the parietal cells are decreased, the acid is decreased, the intrinsic factor is decreased. So all the procedures are going to have this challenge of B complex vitamin. So to summarize, these are the sites of various nutrient absorption. One thing to remember, there is no absorption in the stomach, but it is important for starting the digestion of various food materials. And then you have this folic acid ion in the proximal part of the small intestine. So where the proximal part of the small intestine is bypassed, you are going to have this challenge. Then in the middle part, you have the protein, fats, calcium, magnesium, trace elements. Later on, you have the fat-soluble vitamins, and terminal ileum is important for B12 bile acid, and water and electrolytes in the colon. So wherever this small intestine is interrupted at various places, that is going to be the challenge for nutrition. So if you take procedure-wise, now this is the adjustable gastric band, which is not so popular now, but when we started with the bariatric practice, this was a very popular procedure and very difficult to manage post-operatively because it depends lots on the patient's compliance. So this is the band, and this is a small stomach pouch which is created, which starts behaving like a new stomach. So the anatomical changes, creation of an hourglass stomach, smaller upper pouch which acts like a new stomach. So obviously, because the patient is going to eat less, small pouch, volume restriction, protein challenge. Less ghrelin effect, the patient will be feeling hungry off and on. So, and if the patient tries to eat more, especially if it is a adjusted band, then the patient may vomit. Repeated vomitings can give rise to B1 deficiency, and so we have to keep in mind, if a band patient has persistent vomitings, then we have to think about the B1. Second is the sleeve gastrectomy. The anatomical change is formation of a small stomach tube, and this part of the stomach is resected and removed. However, here the pylorus is intact and there is no duodenal exclusion. One thing to remember is, because the pylorus is intact, if the person overfeeds himself, then the food will come out. So the patient will vomit. So we have to be very careful about educating the patient regarding the volume size of the food that they are going to eat, and see that they don't vomit. And if they do vomit, again we have to think of the deficiencies that the person can enter into. So volume restriction, protein intake, again a challenge, less acids, so calcium, iron, less intrinsic factors, so B12 is a problem. And another thing that we have studied is that this resected sleeve has a very higher motility. So formation of the chyme will be a problem, and that's why the patient has to chew properly so that undigested food does not enter into this pouch. In the gastric bypass, the anatomical change is formation of a small stomach pouch, which is directly connected to the intestine. Excluded stomach, which is there in the body, it's not removed. The duodenum, the upper jejunum, is also bypassed. So you have to remember, okay, what are going to be the nutritional challenges. vagotomy partial, and there is deliberate malabsorption. And so the challenge will be again volume restriction, protein, less acid, so B12, protein, iron, intrinsic factor deficiency, duodenal exclusions, so think of the calcium, magnesium, folate. The mixing of the food and the digestive juices is at the lower end, so all that we eat is not absorbed. Because there is malabsorption, fat soluble vitamin deficiencies. So these patients need to be supplemented, but then we are not very sure that oral supplements are completely absorbed. That is another field which is not completely studied in bariatrics about what happens to the drug delivery, the drug absorption after surgery. So that is another thing. So that's why we give more of sublinguals and intramuscular or IV nutrition. Then there is this dumping. The very malabsorptive procedure, more the malabsorptive procedure, more will be the nutritional challenge. So this is the biliopancreatic diversion, and this is BPD-DS, excellent surgeries for diabetes, but because of this severe malnutrition, where we can see this 50 centimeter here, this word common limb, so this is the only part of the intestine which is where the food gets absorbed. So that is a big challenge here. But this is not much done in India, so we don't have to worry about it much, but we need to know because it has excellent anti-diabetic effects. So post-operative nutritional supplement, because prevention is better than cure, we put the patients on protein supplements because we know whatever the international guidelines suggest, our patients are not going to meet these protein requirements just through the diet because of the volume restriction. So we should give them protein supplements. And then other nutritional supplements and other screening that we have to keep a watch. Like I said, B1, if there is persistent nausea, vomiting, B12, almost all patients need. So this is included in the regular supplements. So low acid, low intake. You can give them oral, you can give them intranasal, you can give them IM once a month, or you can give them once in 3 to 6 months. We sometimes give them IV, like especially the rural patients, when they come for follow-up every 2 to 3 months, we give them what is called as nutritional cocktail. So that because we are very sure they cannot afford the supplements which are expensive, the compliance is not so good, they may not understand the importance of taking a supplement at a particular time. So it is okay to give them IV. Folic acid should be included, especially in the young females. Vitamin A, vitamin K, and E only in the severe malabsorptive procedures that we do. We are more careful in that. Most important, again, vitamin D, calcium citrate, and phosphorus. The calcium carbonate, which is routinely used, is not advisable because there is no acid in the body. And so calcium citrate, which is acidified form, is advised, and it is given to be given in divided doses along with vitamin D. Other important thing is iron in the young females, and you should remember that if you give it a vitamin C, the absorption is better. Zinc is important in those with any skin problems, hair loss. Zinc and copper, and also in male hypogonadism. So see that we give some copper when we are giving zinc. Then you have copper 2 milligram per day. And serum chromiums we have studied in a small group. Patients had sweet cravings. For example, a patient has developed some type of anemia, has not come for follow-up, comes with an anemia which is mixed. You have to think of these things: iron, vitamin B12, folate, protein, copper, zinc, and even selenium for those very malabsorptive procedures. So we presented a small paper on serum chromium levels, whether they correlated with our post-operative sugar cravings in patients who underwent gastric bypasses. And we performed this assay at 6 months and 1 year. And we found that the mean serum chromium in the post-bariatric patients was much less as against the normal patients. And this difference was statistically significant, but our group of patients was very small. We gave them some chromium, and they did improve. So this is one thing that we think of in those who have sweet cravings. There are other special conditions which can give rise to nutritional challenges. One is dumping, which is if the patient takes a very high calorie, especially a high sugar contents. We've seen that dumping can occur, and then the absorption becomes a problem. Some patients develop reflux. There may be food intolerance. There will be renal stone formations, oxalates with those who have less hydration. Hair loss is a very common complaint. In the first 2 to 3 months, it is okay. The patient will come out of this. But if hair loss occurs starts occurring after 1 to 2 years, then we have to start thinking of severe iron deficiencies, and we have to investigate the person properly. Sweet cravings, as I said, we have to look for chromium. pregnancy is a big challenge, and to see to it that the patient remains in touch with us and see to it that patient is already on folate. Decreased physical activity, especially if a patient undergoes some accident or some major surgery. So in this case, we have to be very alert. If the patient develops some cancer, is on chemotherapy. Again, adolescents, elderly, where their eating habits are very different, elderly patients, because they are not very mobile. Another thing to remember is intestinal adaptation in malabsorptive procedure, which is a compensatory mechanism that follows this abrupt uptake in the mucosal surface area. And it starts post-operatively, it goes on up to 3 years. So this is one thing that we have to remember. So different procedures, and there are good results, but as non-surgeons, our responsibility to see that the patient is on a nutritionally correct diet. And what happened?
Time is up.
Okay. The patient is on a nutritionally correct diet and supplement properly, and see that you educate your team very well. Thank you so much.